The next talk is by Dr. Unnikrishnan, Dr. Unnikrishnan Nair, and he'll be talking to us on the concept of multimodal imaging and clinical applications. Though I have listened to many times on this particular talk, I still would like to listen to that.
Thanks to AIOS for the invitation for this talk. So, a couple of things you have to know regarding any imaging modality is that the whole is greater than the sum of the parts. You have to look at everything together. The next thing is order a test only if you know what to do with the result. The typical example being Brexit. People ask for the Brexit, and once they have the reaction, they don't know what to do about the Brexit. So that's one thing. Imaging can tell you only the processes that happen. They don't tell you the diagnoses per se. And there are patterns all over the place to interpret. So multimodal imaging is a group which you have all these imaging modalities together. So and what is the importance? The concept of multimodal imaging is that they tell you some stories. So let's go through some of these stories. So you have first we'll deal with geographic atrophy. You have so many imaging modalities, but this is the essentiality. What do they do for you? First, they give you a definition. So everything is now called, it's not called geographic atrophy, it's called macular atrophy. And this is it. It's divided into something called C-RORA, I-RORA, which I'll tell you. And that itself, you can have with and without neovascularization. So this is the new classification. And what do you mean by C-RORA? So this is what it tells you. It helps you to define what atrophy is. C-RORA is when you have a contiguous area of more than 250 microns over there where there is no outer retina, no RP, and the whole transmission. This is the transmission defects. You see that the light is transmitted, and that's called the transmission of more than 250 microns. And this is an example when you see geographic atrophy, but when you see the extensive transmission more than 250, this is called C-RORA, complete RPE and outer retinal atrophy, C-RORA. And then you have, obviously, if you have C-RORA, you'll have I-RORA, or incomplete, when it is less than 250 microns. It's a small area of atrophy. So first here, now geographic atrophy is given a name, two names, C-RORA, I-RORA. And next comes to the next story. The next story being hyperreflective dots. Why is this important? You see small dots. So these dots are called hyperreflective dots. They're the first sign of RP atrophy. So that's the story. You can predict RP atrophy, predict geographic atrophy. So you see these dots, and there you see the PED flattening. And these are another example. This is yet another example of hyperreflective foci. You see the RP cells detaching from the RP, the first sign of atrophy. And this is a 10-year-old follow-up. You see the dots, you see the changes happening, and you see atrophy happening over a period of 10 years. And this is a good example of geographic atrophy happening.
Dr. Unni, can you just disturb? Can you just use either the what do you call no, just to show them the PGs.
Yeah. So
Either the mark. Yeah.
Yeah. So I'm using it. It's not very bright. That's a problem. Okay.
Can you use that tracker?
Yeah. Okay.
Yeah. So that they can really understand what.
Yeah. So the previous we were showing the atrophy. This is another thing. It's called hyperreflective vertical columns. So what I want you to look here is that, do you see these vertical columns going up and down? So when you have a small area of RP, there is a hypertransmission going beneath it, which tells you that the RP is getting atrophic at that particular region, and you see these hyperreflective columns. And this is yet another column. Here there is no RP, so the OCT light gets transmitted to a deeper layers. It's called a hyperreflective tail also, it's called. And you see this, and when this happens, it leads to a condition called nascent geographic atrophy. That's a geographic atrophy that's about to come. It's called nascent because you see here, you see the layers dipping down. That is because there's lack of vertical support and the layers go down. So this is a particular condition. It's called nascent geographic atrophy. It precedes geographic atrophy. The classic way of measuring geographic atrophy is using yet another tool called fundus autofluorescence, where you see, this is a typical description over a year period, you see a nose getting attached, which is islands of geographic FAF, that is fundus autofluorescence hypo. Hypo means there is no RP and it gets enlarged, and this is how you measure dry AMD. There is yet another modality where you look at the in fundus autofluorescence, you look at the area around the hypo place. If you see hyperautofluorescence, and therefore it is divided into multiple patterns, and of which a pattern called the diffuse reticular pattern has the greatest. So now you have a way of identifying GA before it happens, measuring GA, and also predicting how GA progresses. So the take-home message from this is that you have a disease where you can identify, now you know how to define it, how it comes, how it progresses, and how to measure using some additional characteristics of OCT. Now let's look at wet AMD. So the angiography part has been well done. I just want to make one point here. There is a very important, you just need two angiographic patterns, an early pattern and a late pattern. The early pattern, if you see here, it gives you the definition of the angiography in a classic, and the late pattern shows the fuzziness. So early definition of a classic CNVM in an early angiographic picture, and fuzziness in the late, that is a typical diagnosis of a classic CNVM. And the classic OCT diagnosis is a fusiform lesion like you see here. So you see in this particular picture, you see all the angiographic lesions, but the OCTA brings out the next thing. It's called a vascular net. A classic shows a typical lacy pattern vascular net. So the OCT is very useful for classic membranes, not so much for occult membranes. So there are various patterns. You have the lacy pattern, the Medusa pattern, where the central vessel is the center, and like a halo it goes all around. Then you have a C-fan pattern when it goes only on one side, and then you have a fishnet pattern. And why are all of these important? Because the response to treatment is different. So now you have a disease where you can identify the different patterns and know, when I give anti-VEGF, it may not respond well, it may respond well. And why does it happen? You have recurrence. And this is, I want you to keep this image ingrained in your minds. This is a typical image of a recurrent CNVM. What happens? You have an anastomotic channel going all around the membrane. And then you have small vessels attaching in between it. This is the typical picture of a recurrent CNVM. When it comes, you have the anastomotic membrane followed by the internal lesions. And here you see another picture, anastomotic membrane around it, small vessels in between it. Here you see two parts. The part I'm showing you here is a regressed part, filamentous vessels. And the part I'm showing you now is the active edge, where you have the small vessels recurrence. So OCTA is an important modality to prove to you recurrence of a CNVM. So this is along the same lines. Okay. But when you know that a CNVM is going away, this is the appearance. It's called a prune tree or a dead tree. All it means is that you have long filaments without any intervening small vessels that I showed you. That shows that the CNVM is inactive. And this is another, it's called skeletonization. You can see the pattern. All the vessels look like the typical radiological skeletonized appearance, where there's no consistent flow inside them. So this is an OCTA picture of a skeletonized or a regressing membrane. So we'll just skip this, and this is an important thing to know. This is one we said, how do you predict a CNVM? So this is the thing, it's called a non-exudative CNVM. You have a picture here which looks pretty much normal. There is no activity except for this. This is called a double layer sign. What is it? It's a separation of the RP from the Brooks membrane. You see a small gap over there, but there is no activity. And when you do an OCT angiography, you find there's a vascular network over there. So you have a vascular network, or what you would call a CNVM, but there is no fluid or hemorrhage. This is called a non-exudative CNVM. This is a picture, another picture of a non-exudative CNVM. And why is it important? Statistically, up to 22% of non-exudative CNVMs become full-blown CNVMs in 1 year to 15 months. So that is why you have to identify. So angiography still, the story is that angiography is used for some diagnosis, not all. OCTA gives you different types of vascular nets, so you can predict response patterns. OCTA allows you to find recurrences, and a diagnosis of non-exudative CNVM, if you can find, you can tell the patient to be careful for the next 1 year to make sure that the patient doesn't get a full-blown CNVM. Pachychoroid. So pachychoroid is something that you know, CSR, there are many manifestations, and on the right-hand side you see dilated blood vessels, choroidal blood vessels. I'd like you to see this picture. This is a picture of the vortex vein engorgement. So this is the pathogenesis. The vortex veins are engorged, there's an outflow problem, and that is transmitted to the choroidal circulation. So this is upstream. And then as you go downstream, you have thickened choroidal vessels. Pachychoroid. This is how pachychoroid happens. And when pachychoroid happens, you can have a full thickness and you can have just the halar vessels getting thick. So this is upstream and downstream pathology of pachychoroid. And this is what happens. When the problem in pachychoroid is not because of the thick choroidal vessels, it's because they cause inner choroidal attenuation. They cause the inner choroid to thin out, and that's why you have your CSRs, and all those conditions are because of the ultimate downstream effect, that is the inner choroid being thinner. Picture, you all know CSR, and this is what I like to show. You have a color photo or multicolor, and this is all it shows you. It shows you a thickened vessel here, it shows you SRF here, it shows you a possible PED here. So all the information you require is available in this multimodal diagnostic tool. And again, autofluorescence is a method to identify different pictures. I just like to show you one thing. This is a picture of a tract forming, an RP tract where fluid was there and the fluid caused damage and it hyperfluorescizes over time. And eventually it forms this disease in which you call it a decompensated CSR or sick RP syndrome or diffuse RP epitheliopathy. This is a new diagnosis or recent diagnosis called PPE or pigment epitheliopathy. You have a pachychoroid vessel over here, a thick vessel over here, and something on top of it. That's a problem. And when you look at it carefully, you have all these small changes on the surface. And I'd like to show you just quickly what these changes are. You can have a small split in the retina or a small elevation that looks like a drusen. So this is why is this important? Again, the story here is that in some cases it has been described that through this small break you can have a new vessel forming. So this potentially could be a precursor lesion to pachychoroid new vessel disease, and that is how important diagnosing these conditions using multimodality is. Another condition called pachychoroid neovasculopathy. Here it looks virtually normal, nothing is seen, but at this area you see a small lesion. And on OCT angiography, which is a diagnostic tool for pachychoroid neovasculitis, you have a thick choroid, but it doesn't go to PCV, it just produces a small membrane, a type 1 membrane. This is called pachychoroid neovasculopathy, and this is how you see the membrane over here. So again, PCV, you have multiple modalities. You see basically in PCV, you see a group of polyps, you see a thick branching vascular network or BVN. That's what you see over here, a BVN with polyps at the tip. And I'm just skipping these two, those are videos. And this is the typical appearance. You see a peaked or thumb PED, notched PEDs, a double layer sign, SRF, and intraretinal fluid. So these are the critical diagnostic features of a PCV in one slide. And obviously the pachychoroid. So this is a representation of how the polyps look on ICG and fluorescent. Now polyps are not called polyps. This is one I want to highlight. They're called PLs or polypoidal lesions. BVNs are not called BVNs, they're called BNNs because they've been discovered to be neovascular. So this is, if you want to talk like a retinal specialist, this is how you talk nowadays. But what I want to show this slide is that we've discovered that BVNs are not uniform. There are many types of BVNs. Trunks, glomeruli, and sticks. They're different appearances. And why is this important? This explains to you that PCV is not a uniform disease. There are multiple variations, and that is why they do not respond to anti-VEGF uniformly. So I'm just going to skip this wrap because it's a bit too complicated even for me sometimes. And we'll go to one of my favorites, MACTEL. MACTEL is a very strange disease. Sometimes difficult to diagnose, sometimes stares at your face, sometimes you don't know what to do with it. So here you have two pictures on both sides. The same picture, one is using multimodal imaging, color, true color confocal, and you see everything brightens up. Just a few more slides here. everything brightens. Of the same picture in regular fundus photography, you don't see anything. So multicolor enhances the pigment, enhances the atrophic areas, and is pretty much diagnostic in Mactel also. Here you see something different. You see a small hemorrhage over there, and this is what happens in OCTA in different levels. You see different things happening, but eventually at the avascular zone in the end, you see a blood vascular network happening. Okay, this is the CNVM on OCTA in the avascular zone, which is normally supposed to be empty or devoid of any vasculature. So these are the other features of Mactel. You have inner and outer lamellar defects. You know all these things. There's something, a thick plaque over there. This is called a pigment plaque. Subsidence, when the tissue collapses and falls and goes towards the outer retina, you see the tissue going down over like this is called subsidence. And there's a new change called ORA or ORAH, where you have all these lesions down in the lower part over here. And the typical end stage of Mactel would be an SRNVM. Note, it's not a CNVM, it's a subretinal neovascular membrane. And what do you think of the pictures on which side? Which is a SRNVM, the right or the left picture? Is it this one or this one? Are both of them SRNVs? The right or left? This or this? Both. Okay, you're right. The one on the left because I told you about 5-10 seconds earlier. That's the SRNVM. The one on the left is an artificial artifact caused by atrophy. The vessels go down and it looks like a CNVM, but it isn't. I'm just skipping. Diabetic retinopathy, you know absolutely everything about it. This is a typical wide field. This is not an ultra wide, it's a wide field picture. It captures everything. This is an ultra wide field picture. It captures everything, but it's hard to interpret sometimes. A typical picture of DME with the typical features: submacular detachment, spongiform edema, cystoid macular edema. Your three edemas that you have to deal with. Disorganization of the inner retinal layers, it means this. On this side you see all the retinal layers clearly. On this side you cannot make out the inner retinal layers. This is called disorganized retinal layers. This is parallelism, when the layers become not parallel to each other. Again, you have a hyperreflective dots, disruptions, and I'm just skipping. These are not so critical or crucial. So this is what you need to know. This is a crunch phenomena. When you do too much laser or too much anti-VEGF, this is what happens, and this is beautifully picked up by wide field photography. A normal FAZ, and how many of you think that this is macular edema, ischemia? Nobody thinks it's macular ischemia. Do you see the FAZ enlarged? Okay, is it macular ischemia? Yes, no? Okay, it's not macular ischemia essentially. This is an interesting way of using multimodal edging. Do you see the cystoid macular edema there? The macular edema has pushed all the vessels to the side. So when you do an OCT, it looks like macular. So this is kind of, when you treat the CME, the vessel, the FAZ becomes smaller again. So this is a crucial thing to know, that you have to correlate two methods of evaluation, not just one. So last part, this is a game changer in diabetic retinopathy, ultra wide field imaging. Why? Because now you have the ability to recruit more, find more PDR in the periphery, find more ischemia, treat lesions better, and please know that peripheral ischemia is now related to unresponding diabetic macular edema, and that is why ultra wide field imaging should be a part of the diabetic workup nowadays. So thank you very much. These are some stories you can learn about all these things. Thank you.
Thank you so much. I'm sure that we just have some questions to ask. I know that you have a lot of photos to show. Just want to compliment him on one thing, that what if PGs or somebody wants to attend the retina meeting, which he conducts year on year, one of the very good meetings. Probably you can just mention which month. I just forgot the month.
July 26, 27, 28. On the 28th of July, we have a specific basic retina imaging course only for postgraduates that day. So 26, 27, 28 is a retina imaging congress in Trivandrum, and 28th is the BRIC, the basic retina imaging course. So you're all welcome to come. Registration is free. Yeah.
Thank you.
Thank you.